Thank you for that introduction, and I'm very excited to be here today. It's great to be able to talk about research that we're doing in the community with community members. I'm going to start by talking a little bit about the aging of America and Alzheimer's disease. As you all know, America is aging. By the year 2030, 1 in 5 Americans, or 20% of our population, is going to be over the age of 65. The fastest growing segment of our population is the 80-plus age range. And this aging of America is going to bring with it some significant healthcare challenges. One of those biggest challenges is how we're going to care for the increasing number of individuals with Alzheimer's dementia. Alzheimer's dementia is a disease that increases with age. Currently, about 5.2 million Americans suffer from Alzheimer's dementia. And if no cure is found by 2050, it's estimated that 16 million Americans, with 8 million of those being in the age group 80+, will suffer from Alzheimer's dementia. Currently, the cost of skilled nursing home care is about $70,000 a year. And the Lewin Group estimates that by 2050, if no cure is found for Alzheimer's dementia, Medicare spending could reach $1 trillion. A lot of care is being done at home by family members and friends, and that actually saves the US economy about $144 billion a year. This is according to 2009 statistics. But we do know that caring for someone with dementia does bring significant economical, social, psychological, and physiological risk. So data suggests that care partners who are caring for an individual with Alzheimer's dementia are at higher levels of emotional stress and physical health problems in comparison to other caregivers of other types of diseases and to non-caregivers. So in terms of thinking about interventions or ways to assist individuals who are having cognitive difficulties, it's important to also keep in mind the care partner. So the current intervention that we've been working on is a cognitive rehabilitation multifamily group intervention. And the goals of this intervention are to delay and compensate for the functional disability in the person who's having cognitive difficulties, to boost the care partner's confidence and competence, so it's important to us to work with both members of the care dyad, and then to enhance the care dyad's interpersonal relationships, coping skills, and quality of life. So now I'm going to talk a little bit about the development of our intervention, where it came from. The new medical guidelines for Alzheimer's disease now recognize a continuum of phases. The first being a preclinical phase, where there's changes occurring in the brain, but we're not so much seeing them in terms of cognitive difficulties with memory or thinking abilities, or in people's abilities to function on an everyday basis. There's a transition phase after the preclinical phase called mild cognitive impairment. And this is the group of individuals that we've been working with. These are individuals who are starting to show some difficulties, having problems with memory, having problems with thinking skills. They're still able to function independently, although there are problems with some more complex activities of daily living, such as managing finances or cooking complex recipes. And many of these individuals will go on to transition to Alzheimer's dementia. And when they're given the diagnosis of dementia, this is the point where they're having difficulties functioning independently in their everyday lives. Now, the fact that in the last couple decades, we've been able to recognize or diagnose people earlier in this mild cognitive impairment phase has opened up new ways to think about interventions. So before, typically what was done, the Alzheimer's individual was put in a group in one room, and the caregiver was put in a group in another room. And these individuals were worked with different therapists because there were different needs that were involved. Well, being able to diagnose people earlier in this period of mild cognitive impairment opens up the ability to work with both members of the care dyad together. These individuals are aware that they're having difficulties, and most of them are very interested in being proactive, finding strategies that they can put in place to assist them as the cognitive skills start to decline. So another thing about being able to work with people in the mild cognitive impairment stage is that we can be more proactive. We don't have to react to the symptoms, but we can actually start putting things in place. In terms of the development of this intervention, I had done some earlier work with people with traumatic brain injuries with teaching them how to use an external aid, a memory notebook. And then we decided that we wanted to try some of this work with people with mild cognitive impairment, and we wanted to bring their spouses in as a support partner in terms of learning these strategies. So our early work was a 7-week intervention with 6 couples. They met twice a week for 2 hours, and we taught them how to use the memory notebook as an external aid, as well as other sorts of memory strategies that they could start putting in place in their everyday lives. We also teach from a more holistic point. So how can you use the memory notebook to also increase positive things like social networking, exercising, things that are going to support quality of life. And one of the things that I like about the memory notebook as a cognitive strategy is that it can help people plan for future events. So just like the daily day planners that many of you use, it can help people get to appointments. It can help them plan to do today list and then schedule those in. But it can also help people who are having significant memory difficulties look back and see what they had done on previous days. So we also teach them how to journal events that are occurring either hourly or at breakfast, lunch, or dinner into their memory notebook so that they have some sort of record of what it is that they've been doing that they can refer back to. So our early intervention group, we did find that our care partners were reporting decreased depressive symptoms after the intervention. For individuals with MCI, we found that they felt more confident that they could go to family members and friends and ask for support. We didn't know whether this was the memory notebook intervention or some of the social support that they were receiving from the group, because as it turned out, that social support was a very important factor that they were continuously speaking with us about too. We found that they were using more memory strategies in their everyday life, as self-reported by some diary measures. We also found that on laboratory tests where we allowed note-taking, that they were taking notes, they were referencing their notes, and they were demonstrating to us that they had acquired these strategies and were able to apply them. One of the things that we didn't find was changes in self and significant other report of everyday memory lapses and of being able to do more activities of daily living independently, more complex activities. And of course, one of the things that we want to be able to show is that this intervention is significantly helping people in their everyday lives. Now, there are some issues with how really is the best way to measure outcome in terms of everyday performance. So that may be one thing that unfortunately hinders research in this area because we just don't have a lot of good methodologies. But another thing that we were left with was really how can we make sure that they're transitioning what we're teaching them in our treatment into their everyday lives. So you all know that it's easy to talk about wanting to use a new strategy, but it's really difficult to actually take that strategy and start using it on a daily basis in your everyday life. So we began to ask the question of how can we get these memory strategies integrated into the everyday lives of the care dyads? And in speaking with Dennis and doing some research and seeing what happened in our first group, we came to the idea that perhaps we could do this by combining our cognitive rehabilitation with multifamily group psychoeducation. So what is the multifamily group treatment? Well, it's a psychoeducation management strategy that's designed to help families cope and manage symptoms of medical disorders. So it's come out of work with schizophrenia patients, and Dennis has adapted it to other medical patients, spinal cord and traumatic brain injury. 6 to 8 families work together with 2 clinicians, and it's actually a lengthy intervention, so it's over a period of many months to years. And the multifamily group treatment has a strong psychoeducational and counseling component, and it also has an interactive real-world problem-solving component. And this was one of the aspects that was important to us in terms of helping them develop plans and actually implement those plans in their everyday lives in terms of how to get these strategies into their everyday lives. Learning in the multifamily group provides an opportunity for group members to learn from each other. And families report not feeling so isolated, feeling connected with other people who are going through similar sorts of experiences, and then the opportunity to be connected with more professionals. So I'm going to talk a little bit about what our combined intervention now looks like and some of our preliminary data. To date, we have had 10 care dyads participate in our treatment group and 10 care dyads who are in standard care. So our standard care is just the typical medical intervention that they would receive. You can see the average age of our MCI participants is about 70 years old. Right now, we're having some issues with our randomization because we have more females in our intervention group, and their education is a little bit lower than those in our standard care group. You can also see some information about our care partner group. So here's a little bit about the study structure. We do pre-assessment with both standard care and individuals in treatment. It involves neuropsychological evaluations and blood draws. So one of the other things that we're interested in is physiological health markers. So we're looking at some biomarkers, some cytokinins, that may allow us to look at whether we're decreasing stress levels at a physiological level in both individuals with MCI and their care partners, in addition to our behavioral data. For those who are in the treatment study, the structure reflects what comes out of the multifamily group intervention. So first, there are some joining sessions with the care dyads where the clinicians meet with each member of the care dyad and get to learn about their strengths, their interests, their skills, what their current needs are, the impact that the memory difficulties are having in their everyday life. Then we have a psychoeducational workshop. That's a half-day workshop where we talk with them about mild cognitive impairment and dementia. We pique their interest in the intervention. We expose them to the other members of the group and start that social networking. Then the 10-week treatment intervention starts. We meet twice a week for 10 weeks for 2 hours. And some of you who have done clinical work are probably saying, oh, you know, that's a lot. Or do people actually come? And I can tell you that people actually come and they do not like to miss it. We have almost 100% attendance. We've run 2 of these groups now, one in Pullman and one in Spokane. And it's great to see how excited people are about coming. They're learning strategies, they're being proactive, they're having the opportunity to talk with other people who are in the same phase of the kind of disease progression, and they find it to be a very supportive and positive environment. Then we do post-assessment, and this is the neuropsych evals and the blood draws from both standard care and the treatment group. We then enter into a 9-month maintenance or booster phase with the treatment group. So here we meet with them once a month to encourage use of those strategies, to continue with some of the training, and then to help support the group actually supporting itself after the treatment intervention is done. So the treatment group that I talked about before, that was our pilot group, they actually, 4 years after the intervention, still meet for coffee once a month. It's absolutely amazing, and they did that all by themselves. The MFG is designed so that the group will eventually become their own support group. And then we do a follow-up assessment at 1 year, because it's going to be important for us to understand whether we're having any lasting effects on individuals with mild cognitive impairment and their care partners. The format of each session is very structured, following the MFG format, with some changes that we've made based on introducing the cognitive rehabilitation. So there are 10 to 15 minutes of initial socializing. Then there's a go-around where you check in on the plans that people had developed to put these strategies into use in their everyday lives. There's the cognitive training, and we actually have a workbook. You can get some of that out, maybe pass it around. You want to grab that? Okay, so we have a workbook that we teach people from. We've also developed a treatment manual for clinicians. Wait, Dennis, don't go. Yes. And I'll pass around to the memory notebook. And this can be adapted to other things like PDAs if you've got someone who's very tech savvy. So after the cognitive training part, we have a problem solving where we teach them how to then come up with a plan to integrate this, and I'll show you this in just a minute, and then the final socializing. So in terms of the cognitive training workbook, when you get a chance to look at it, you're going to see that we're not just focusing on memory strategies themselves, but we're also taking a very holistic perspective. So once you've learned the strategies, how can you use those to help increase exercising or increase your social network or better your nutrition, things that we know can have positive impacts on health and hopefully perhaps delay some of those changes that may occur with cognitive decline. We also talk about the impact of their memory problems on them, their care partners, other people in their everyday lives, communication skills with spouses within the group. And then we also do talk about things like planning for the future. So it is a very holistic but very proactive program. In terms of problem solving, at each session, or most of the sessions, based on the information that we've taught them during that session, they come up with a goal for what they want to do. So I want to start learning how to look at my memory notebook on a regular basis, and why is that important to me, so that I can start being able to implement this strategy in my everyday life. What sort of plan are you going to use? Some people choose to use things like a watch alarm that goes off each hour and signals them to write in their memory notebook until it becomes an overlearned routine or habit. Or maybe I'm going to sit down at breakfast, lunch, or dinner with my care partner, and I'm going to write about what's occurred during those past hours. So people can come up with different strategies that fit them and their individualized needs. And that's one of the great things about integrating this, is we found a way for each care dyad to actually make decisions about what's important for them on an individual basis and come up with a plan that's going to work for them. Okay, so here's some very preliminary data. This is the 10 care dyads in treatment and the 10 in standard care in terms of looking at their pre-test to post-test, which is about 3 months from beginning to after the intervention. In terms of using these strategies, is our treatment group learning to use these strategies? They are. They are note-taking, they are problem-solving at a much higher level than, or a significantly higher level than before the treatment. And in fact, our standard care group is staying about the same. They're in orange, or actually going in the reverse direction, where this is our treatment group who is significantly putting into practice more of these strategies after the intervention. And they're also self-reporting that they're using more of these strategies in their everyday lives. Here are some of the outcome variables that we use with both the care partner and the individual with mild cognitive impairment. We're looking at things like depressive symptoms, quality of life, coping strategies, and then of course social support and relationship quality. And we are finding that our treatment intervention, our individuals with mild cognitive impairment are reporting less depressive symptoms, but their depression or their symptoms report to begin with is quite low. Quality of life, they're reporting increased quality of life. Coping strategies, the care partners are reporting better coping strategies after the intervention, but we also have our MCI participants in standard care who are reporting better coping strategies too at post-test. No changes yet in social support or relationship quality, and we're going to be very interested to see as we get more individuals into the intervention and as we get to the follow-up, are we able to hold some of these effects, or could some of these effects have delayed effects, or can we at least keep them constant if standard care starts to show some more negative changes? We haven't yet to date seen any changes in care partners' report of burden. Our care partners in the treatment group are actually reporting more burden overall than our care partners for the standard care group. And we also haven't seen any changes yet in report of kind of everyday memory lapses and everyday activities. So those are some things that we're really after, and we're hoping with increased numbers and with follow-up, we might be able to see some more there. In terms of focus groups, after the interventions, we've talked to the groups. A number of themes have emerged. One of the biggest is not feeling isolated, having that social support, having other people who are going through the same thing. And then the other big theme is that many of these individuals are feeling much more empowered. They feel like they have a game plan, they have tools now to help them compensate for their memory problems, and they have psychoeducation, so they have a better understanding of the process and what are some of the things that they may face in the future. Here are some quotes. There's a record, we can look it up, and I just feel so much more confident in our life, and it's given me confidence to know that we can handle this. And I think, you know, the neat thing that you can see in there too is the person's just not talking about themselves. They're talking about the care dyad, themselves and their care partners working together to face what is coming in the future. Here's another gentleman. I was a tough sell, big tough guy, I don't have a problem. I did have a problem, so I had to wade into it and recognize where I was and how much better I could be. Or we're not alone out there. I mean, there are other people going through the same thing, and I've learned a lot from what other people have said during the sessions. The reason why I look forward to joining the groups was that I was looking for something that was proactive rather than just being reactive. So that's where we are right now in terms of our intervention program. For those of you who are clinicians or may be able to get this information out, we have brochures, and we would love it if you would take these brochures and put them in places where people may be able to have access to it. We're hoping to start another group in Spokane. So we would welcome any input that anyone has or any ways that you can assist in getting this information out to people. It is a free program, and actually we do pay them an honorarium when it's done, and they get to learn these strategies, get the notebook, so that's probably enough said for plugging help with getting people into our intervention.
Well, it's great to be here. I'm excited to be working with Maureen. This is the kind of study I've been wanting to do for a number of years, and just the timing happened, and we were able to develop it, so it's really exciting. What I'm going to talk about is, and here's some of our contributors, which we should not overlook. Diane Norell, especially, she's worked on this model. She's kind of the expert in MFG and has been with me for 20 years working on that, starting with schizophrenia. And Lauren Warren is our project manager, postdoc of Maureen's. David Greeley is, Dr. David Greeley is a neurologist who's our sort of our medical director for the study. And then those are all of the graduate students who are working with us. Chad and Christina and Laura have been our clinicians, and we videotape all of our sessions and have supervision, so we're looking to show fidelity to the model, or being able to demonstrate that. So the other work that has benefited from this model is the area of brain injury and spinal injury. And most recently, as Brian mentioned, I was asked to collaborate with some colleagues on the East Coast at Mount Sinai Medical Center and Duke University. People who I had known over the years, had reviewed their grants, and they had reviewed mine, and so on. But I was invited to see whether we could adapt the multifamily group that Maureen was describing to brain injury for veterans. Am I supposed to be over here? Okay, sorry about that. For injured veterans coming back from Afghanistan and Iraq. And there is a great need, and I won't belabor a lot of this because you all are aware of how many people are coming back, particularly combat victims with brain injuries and spinal injuries and a whole lot of other injuries. But the realities are that it takes a great toll on families and relationships in addition to everything else, because people come, they go, they have different relationships, different things to adjust to when they come home. And unlike previous wars, multiple deployments are the norm. In the study that I'll mention, the average is two deployments. And it's much higher than that in some individual. And the more deployments, the greater is the risk of injury, of course. About 20% of people who are combat injured also have a brain injury. And I say also because they typically have other stuff, muscular, skeletal types of injuries. One of our vets said, I didn't even know I had a brain injury. You know, what he noticed was his foot was half shot off. And he was going around trying to carry on with an injured foot, and it was only later that he became aware of having a brain injury. And these are sort of different than the injuries that happen in civilian life, like diving accidents and car accidents and so on. A lot of these are blast injuries, explosive devices. And so, and they can cause, varying degree of severity. This is just simply a slide that shows the different levels of severity of brain injury that clinicians use to classify mild, moderate, and severe traumatic brain injury. We started the multifamily group focusing on people with mild and moderate brain injury. I'm beginning to think that if we use some of the cognitive remediation strategies, we can also begin to work with people who have more severe TBI and help them. Part of the problem with the blast injuries, particularly with mild or moderate TBI, is the challenges of diagnosis. A lot of times the veteran may not remember the event. Often there's a long delay between when it happened and when the veteran actually gets, unless it's a really severe injury, and they get diagnosed. And because of the nature of the blast injuries, it's very difficult to detect brain injury, particularly if it's mild or moderate. And it's because of this action of rotation and force with the blast that it doesn't easily show up on an MRI, but yet you get what's called diffuse axonal injury, which involves shearing of nerve tracts and rotational acceleration, deceleration damage. So these are some of the symptoms of TBI: headaches, dizziness, balance problems, vision, ringing in ears, sleep problems, relationship problems. And how it affects functioning is, of course, dependent on the severity of the injury and also on the location of the injury. But this is a typical scenario where the person has memory lapses. So memory lapses, focus and attention difficulties, starting and completing, maybe starting and restarting projects but not finishing them, getting distracted, those kinds of things are very commonplace. And the problem is magnified by the fact that most people with TBI also have other issues. If you're exposed to a blast or you see a buddy get blown up, you not only have your own injury, but you have the memory and the trauma to deal with. And in our sample, the majority of people who were diagnosed with TBI also had other diagnoses, as you'll see. And what brings them actually into treatment and service most often is pain. You know, that's really sort of the starting point. So Maureen talked about the multifamily group model and described it. This is the original model. Bill McFarlane developed the multifamily group model for schizophrenia. And I started collaborating with him in about 20 years ago. We brought him to Spokane, trained a bunch of clinicians at Eastern State Hospital and Spokane Mental Health at that time. And so we have kind of collaborated over the years ever since then. He is now the medical director at the Maine Medical Center. But this just shows that this is a very evidence-based intervention. There's lots of research that supports it. This is the original schizophrenia intervention. Treatment as usual shows about 60% relapse. Schizophrenia is a relapsing condition with either single family or multifamily groups. It goes down to less than half that. And this is the original evidence base for the model. We then took and adapted it. There are some people from St. Luke's here. Bruce Becker and I wrote a grant to NIDR some years ago, and so we adapted it for brain injury. Just kind of like the way Maureen and I have developed our collaboration with dementia, Bruce and I got to thinking about the similarities and differences of managing something like a brain injury or spinal cord injury. So we did this study, and you can see some of the features of it, and showed that it actually works. Survivors, those people with brain injuries, reported a decrease in depression symptoms and anger expression, and an increase in life satisfaction. And depression and anger are biggies, big emotional sequelae of TBI. And as our work with schizophrenia, we always find that MFG not only makes things better for people with the illness or the disorder, but also their family members. And there we did see a significant reduction in caregiver burden. So these are my collaborators. Actually, I'm their collaborator more. From Debbie Perlich, who's the PI on this Department of Defense funded project, which we're just about through now. Christy Straits-Troster, who is at Durham, affiliated with Duke University. And Christy used to be at WSU way back when her husband Alex was here in the clinical neuropsychologist in Pullman. So our aims were very simply to adapt the multifamily group to address the needs of veterans. We had input from veterans as we were developing the intervention. And we wanted to see if it was feasible and whether it would work. You can't automatically assume that an intervention model which works with one clinical condition will necessarily work for another. And there are many differences between dementia in older couples who have lived together for 30, 40 years and are committed to each other, and young soldiers and their spouses with young kids having a very different family experience. And in fact, a lot of what our multifamily groups look like with the young veterans and their spouses approximates group marital counseling. There's other stuff too around, the disabilities, but the relationship is a huge issue. So here's just a very busy table. The main thing I would draw your attention to is the comorbid And you can see almost 80% of our TBI vets also have PTSD diagnosis, major depressive diagnosis, not so much alcohol abuse disorder, about 30%. So alcohol abuse and particularly PTSD are pretty common. This sort of summarizes that busy table. Over 80% scored above the cutoff for PTSD, and 90% of veterans and 60% of family members scored above the standard cutoff on a self-report scale for depression. And that's very different from our couples with dementia, where the depression levels are pretty low. I mean, we're showing some effect there, but this is way higher. And on average, veterans perform below average in verbal memory. These are some of the major problems. Maureen referenced that this is a problem-solving model. These are the kinds of problems that veterans deal with and that were the focus, using the same format that Maureen described. Cognitive deficits, losing track of important items, missing medication doses, trouble with planning and goal setting. Family and relationship issues are huge. Communication problems. Sleep is a big thing. You know, veterans who come back, they don't go to bed until 3 o'clock in the morning. They can't go to bed if the TV isn't on, and they're up at 6 in the morning and, you know, blaring stereo. And of course, that causes a little marital conflict when that happens, particularly if they're young children and things like that. Accepting limitations, accepting sort of also by the spouse, accepting someone who's changed as a result of the injury from the person that they knew before. And so here's some data. Anger expression on the left side is the veterans' outcomes, and on the right side, the family members. The things with the little asterisks are the things that you should pay attention to. Those are meaningful differences. So anger expression went down, social support went up in the veterans, and then if you get down to the bottom, occupational activity went up in the veterans. Those are 3 significant findings. In the family members, empowerment and burden. Burden decreased and empowerment increased in the spouses. And here's some pictures showing some of those. For the brown one is the Bronx, green is Durham, and the red lines are the combined sites. But you can see the trend. Veterans on the top, anger expression goes down, occupational activity goes up. For the caregivers or spouses, burden goes down, empowerment goes up. Well, that's months in the bottom. Thank you. Should have labeled my graphs. Yes? There is a bit of on anger expression. Yeah, there is a bit of return over the longer period. I don't know that that's statistically a reliable rebound, but it's visible. You can see it. Yeah. Not in this one. This was the treatment development study, so it's not as strong a design as our Alzheimer's study, which has a control group. So in that sense, you know, we have to do, we're basically developing the treatment in this study, getting preliminary data. We've now written an NIH grant to do this in Maryland and also in the Bronx in a multi-site random, and that will be a randomized clinical trial. Mark? That information is there. We haven't really looked at it yet. You know, clearly the alcohol use is pretty obvious, but I think that's a really interesting thing to follow up on, because I haven't sort of pulled it out of the transcripts from the group sessions that we've seen, and it could be a self-selection bias that the people who are coming into our groups don't have a serious drug and alcohol problems. We also screened out those kinds of things. But that, in terms of real world, that's a common problem, and I think it could yield to that. I've actually been talking with John Roll, who's our sort of local drug addictions research expert, about doing a chronic pain and opioid dependence group using this kind of intervention. Thank you. So the focus groups are fairly similar to what Maureen reported. People talk about here a safe place to bring their problems. There's a lot of stigma. There's stigma about dementia, which makes recruiting for studies hard, and there's stigma for young guys who want to come back and become first responders to admit or acknowledge and be public about, even though these are private, but to the extent that they're sharing it with other people. So to them, this was a value, that they had a safe place to talk with other people who had gone through the same kind of thing. And it's really neat to see how they start to help each other and form a bit of a social support network. And I think the last item, the experience gave people hope. And that's, I think, what my experience, the difference between single family and multiple family is that by being with other people, learning and coping and confronting a common thing, you realize that you're not alone and that you can support each other. And it's like Maureen found, 4 years later they get together. We found exactly the same thing in our schizophrenia work. So, summary, I'll wrap up. MFG can be successfully adapted. Preliminary results suggest family members had less depression, less caregiver burden, and a greater sense of family empowerment. Veterans with TBI reported fewer depressive symptoms, decreased anger, and increased social support, coping intervention. I'll end on one thought here. This intervention works great, but it's not widely adopted. There's this whole issue in clinical science that has to do with implementation and translation so that it actually gets picked up and done outside of a research context. And here are some of the lessons that we learned. 41% of the people who qualified for our studies and were referred actually were enrolled. So you think that's a pretty good batting average, but there's lots of room for improvement there. Thank you.
One of the strengths of the capabilities here in Spokane, of course, really does rely on INHS. If you're not familiar with Inland Northwest Health Services, this map just shows you the reach of the facilities in which we have a common electronic health record across the region. We only have a few areas in the Inland Northwest where INHS is not serving the hospital information systems needs. What this means for our research is that we don't have to rely on patients being retreated within the same facility. If you were discharged and you lived in an outlying rural location and you went to a community hospital in that location, we know about that. We can know about that. If you were treated at Sacred Heart and subsequently retreated at Deaconess, we know about that. So this represents a huge improvement in our ability to follow patients for these different outcomes. So the particular outcomes that we were interested in this study, mortality. As I indicated before, we can match information anonymously to the death index and determine whether or not the patient has died. Again, if you lived in Arizona during the winter months, but you were treated here in Spokane and you died, we know about that. Again, that's all part of this complete real-world information that we're looking for. If a patient had an MI, a heart attack, we need to know about that. We can pick that information up by the administrative evidence within a hospital, any hospital in the region. But you know, Dr. Ring is pretty picky. He says, I don't want just administrative evidence. I need to know that cardiac enzymes were elevated. And so we match not only the administrative record, but we look at the laboratory records. And we look for elevated troponin and elevated CK-MB index. That's one of the terrific things about working with a clinician, is that we get the opportunity to do real-world research. We can't rely, many studies rely entirely on administrative evidence. We can do it one step better in this instance by linking to laboratory data. Bleeding events, we were interested at the beginning because of the use of Plavix primarily. Long-term in these patients, there were concerns about subsequent hospitalizations for bleeds. We could use the administrative evidence to check to see if in fact we saw increased rates for bleeds. The revascularization outcomes, both TVR, we can identify through the procedure logs. And for you to think about that for just a moment, this is sort of a complex question. So you were treated, as Mike indicated earlier, so you treated the LAD, you were subsequently retreated. Well, you need to know what vessel was retreated. And so when you start thinking about the level of detail that's required in the old-fashioned way of doing this, this would have required lots and lots of man-hours. Thankfully, we have machines that can do this work for us now. And then, of course, CABG. Open heart surgery is something that we can identify fairly easily from the administrative evidence that's been done for quite some time. This is our flow chart from one of our manuscripts, and it's difficult to read. Certainly if you need this presentation, request, we'll be happy to provide it to you. But in this flow chart, we started out with more than 10,000 procedures, and we're left with two cohorts. In a retrospective cohort design, we studied patients that were in the bare metal stent cohort. There were 2,510 patients or research subjects. And in the drug-eluting stent group, we had 2,304. There's always some questions about baseline comparability in these two cohorts. As Dr. Ring indicated, this is not a flip of the coin. He makes a decision as to whether or not you'll be treated with one of these devices, either drug-eluting or bare metal stent. So it is important for us to understand differences in those cohorts and to statistically control for those within our analysis. And so this slide just shows you a part of the large number of clinical characteristics that we reviewed on these two cohorts. And as you can see, and this is probably not surprising, but I'll let our physician comment on that, we have seen over time in patients treated for coronary artery disease, increase in the percentage of patients who are hypertensive, as well as those who have diabetes, and then of course increases in obesity. So these are again factors that we need to control for when we're trying to examine differences in outcomes between those two cohorts. Mike, any comments you'd like to make on that?
Right, because remember what we're trying to do is we're controlling, you know, the bare metal stent group where patients treated from around 2001 to 2003, and then the drug-eluting stent group was from 2004 to 2006. And even during that time interim, which you'd think wouldn't be that much, you can see that diabetes became more prevalent, and that we could also show that based on the weights in the hospital, that we had a higher percent of patients who were what we call obese as well. So those are all things we have to control. And a lot of these things are, when you have that many patients, like 5,000 patients, it doesn't take very much difference for there to be what's called statistically significant differences between the groups. Like if you look at the top line, the age, it's really only about a 1-year age difference, which most of us would say 65, 66, what's the big difference? It is statistically significant, and we do have to make a minor correction as a result of that. But in general, though, I will say the groups were really quite comparable, which was good to see.
Good, thanks. So let's get right to the results. We're looking here at a Kaplan-Meier hazard function. We've got two functions here. We've got the green line are patients that were in the drug-eluting stent group. We've got the blue line, patients that were treated in the bare metal stent group. So if you're not familiar with this technique, You can see on the x-axis we have the number of months, in this case, of between treatment and subsequent death. And then on the y-axis, we have the percentage of patients who have died within that time period. So at any point, you can look at this intersection and see it. After 3 years, 36 months, you get the idea that we've already got somewhere in the neighborhood of about 15% of patients that were treated will die. And this is comparable between both the bare metal stent and the drug-eluting stent group. And if you look at the p-value, we don't have to go too statistical for a moment, but the larger the p, of course, we know that it indicates that there are no statistical differences. So this doesn't address quality of life issues. This answers one question: was there a difference in death for patients between the drug-eluting stent and the bare metal stent group? And our research found that there was not. And we'll let Dr. Ring comment when I'm finished here on the implications of these findings. Consider, though, MIs. And in fact, as we were conducting this study early on, you can see 12 months, 24 months, we can see a lower rate of MIs in patients in the drug-eluting stent group. And at times, as we were looking at the data throughout the study, we thought, well, this is a reportable finding. But as you can see, that by the time the study was completed, we followed every patient minimum of nearly 4 years. We followed some patients up to 8 years. You can see that over time that we found that gap narrowed, and in fact, we didn't see then over the entire life of the study, we didn't see that there were any differences in the rates of MI among either of these patient groups.
And before you go on, just to sort of point out, you can notice, though, that the green line, the drug-eluting stent group, for the first 12 months, definitely had a lower incidence of myocardial infarction or heart attack, which was probably due to the fact that we had them on both aspirin and Plavix, these two anti-clotting medicines. But then after a month, what is usually the standard of care is for those for the Plavix to usually be discontinued. And then what happens is that there is a slight catch-up. You can see that the number, both groups continue to have heart attacks at a certain rate. You can see that, by 5 years, about 10% of patients did have a heart attack. But you can see that the drug-eluting group actually sort of had a slightly higher rate of heart attacks, so that they kind of closed that gap. Now, still at the end of 5 years, they had a lower rate than the bare metal stent, but it wasn't, as Ken mentioned, it wasn't what we call statistically significant. There has to be enough of a difference that you can say with confidence that this was not a play of chance. That's basically what the statistics, the p-value, tells us.
Hopefully you're getting a sense of the value of this prognostic tool. The ability for us to observe patients in the real world, to see the rates at which these outcomes, these adverse outcomes, actually occur. What about this question that was raised earlier? One of the primary research questions: are patients who are treated with drug-eluting stents, who continue a Plavix regimen for 12 months following treatment, are they rehospitalized for bleeds? And in fact, our study found that no, that we were not seeing differences in rates of hospitalization for bleeds. And again, on the y-axis, you see the hazard rates among these patients. You can observe then what percentage of patients did, in fact, were hospitalized for bleeds. What about this question of target vessel revascularization? That is, once again, one of your major coronary arteries was treated, and then it was subsequently retreated. And how long did it take for that treatment to occur? And this is the first significant finding that we're reporting, a very small p-value, a 1 in 1,000th chance that we're reporting this finding totally by random error. In fact, we have sufficient evidence to conclude that there are differences in these two cohorts. That is, that the drug-eluting stent cohort did experience less target vessel revascularization than patients in the drug-eluting stent cohort. And then finally, another significant finding: what about this question about the need for open heart surgery? And you can see that roughly, the 4 to 5 years following treatment, you can see that just under 4% of patients in the drug-eluting stent group needed to be, as Mike talked about, had to have their chest opened. Not too many. There may be patients in our study that couldn't tell us that they had a stent, but every patient who had open heart surgery knows about open heart surgery, right? They've got the scar to tell us. So this was a significant finding, the freedom, if you will, from CABG as the result of using drug-eluting stents. And to wrap up with implications and conclusions, Dr. Ring?
Yeah, so basically, in summary, what we can say from this study is that, here in Spokane, this data we're presenting is to date, to our knowledge, the longest reported follow-up of patients who were treated with this particular drug-eluting stent. We didn't get into it. There's been basically 2 different types of drug-eluting stents that were available from around 2004. We used, by contract at Sacred Heart, what's called the Taxa stent, or the drug that's used is called paclitaxel. But this represents the longest report so far, 5-year outcomes in patients treated in the real world, as opposed to this very narrow-focused randomized study. And what we can say based on our patient population here in the inland Northwest is that we really could not show that there was any impact on drug-eluting stents in terms of mortality or death or the occurrence of myocardial infarction. But if anything, the trend was reassuring that it seemed to be slightly less compared to bare metal stents. The direction wasn't the right way. The one thing we can say, though, is that the drug-eluting stents did, to some degree, what they were promised. They prevented restenosis and the need for TVR, target vessel revascularization. But I do want to point out that in the original studies I alluded to, restenosis and repeat procedures were decreased by about 50% or more in a very simple, sort of relatively simple patient population. In our hands, it was only decreased by around 20% or so. So we did get some benefit, but it wasn't nearly as impressive as the original studies, and it has to do with the complexity of the type of patients that we take care of. Okay, go to the next slide. I'm sorry. Why don't we go to the one over here? The other thing that was reassuring, too, is that there was concern that, when you start using aspirin and Plavix, in such a large group of patients, that maybe we were putting them at risk for a higher chance of bleeding. But it's reassuring to see that our clinicians were pretty good at picking the right type of patients to get the drug-eluting stents. And we could not demonstrate higher bleeding. And what's really cool about the study is that if say, someone had had the stent put at Sacred Heart, but then they got admitted with, let's say, a peptic ulcer that started bleeding in Colville, well, we knew about that. So that was what's really nice about this particular, about the database that we have. But we saw no difference. The reduction in coronary bypass surgery is probably one of the most dramatic things about this study. And you may ask, well, how come we only prevented TVR by about 20%, yet we prevented the need for subsequent bypass surgery from around 7 or 8% to only 4% of patients needing it? Only 1 in 25 needed to have a bypass over the next 5 years. That's pretty cool. And I think the reason for it is that when we did see re-narrowing, it probably wasn't as extensive in drug-eluting stents as it was in bare metal stents, so that it was more likely to be amendable to repeat treating with additional stents or balloons. So that was our main conclusion, which hasn't yet actually, that's a novel report. No one has yet, to my knowledge, ever reported such a, that there really is an impact on the need for subsequent bypass. So we're excited about that finding.